Oh, we're going to use that. All right. So there'll be a little bit of redundancy here, but hopefully I'll give a somewhat different perspective to what you've already seen. So the implantable cardioverter defibrillator was developed to prevent sudden cardiac death in high-risk patients. It's been incredibly successful for that. But as patients live longer and we stretch out the guidelines about who we can implant them to, transvenous leads remain a problem for this. And that was the reason for the development of a subcutaneous ICD. It wasn't that transvenous leads didn't work or standard defibrillators didn't work. It was the complications from them. And if you look at the lead databases, it's a much bigger problem than many people appreciate. But here from an Optum database of over 28,000 patients, at least 20% of them within 10 years are going to have a lead failure, which is a pretty high number. And when we think now, we were putting in defibrillators to hopefully that we can make them live a year or two, but with primary prevention now being dominant, I mean, most of our patients we expect to live at least 10 years. And the real worrisome one is infection, and particularly when they have bacteremia, whether caused by the defibrillator or secondary to something else. But a patient with a bacteremia, with a defibrillator, a transvenous ICD in place, have almost 1/3 of them will die within a year. Whether they're all from the defibrillator lead or the infection is not clear, but we look at it's much, much higher risk than if it's just a pocket infection in those patients. So it's a problem. So the subcutaneous ICD was developed by a small company called Cameron Health. The challenges of it were defibrillation with subcutaneous rather than intracardiac coils. So it's going to take more energy, sensing of signals, which are much, much smaller than if you're directly making contact with myocardium, inappropriate shocks, which we'll talk about, and then the problem with being able to pace. And very fortunate for me that Cameron Health people, I knew some of them, so I've been involved with these guys since the beginning. So the first step of this was, can we actually discriminate arrhythmias with smaller sense signals? And we did this study called the START study, in which we put electrodes on the chest wall where the coils would be underneath it for a subcutaneous ICD. We did this in patients who were having a defibrillator implant. So they already had defibrillator leads put in, but before we closed the pocket, we tried to induce every arrhythmia we could, atrial fibrillation, SVT, atrial flutter, VT, VF, anything we could, we tried to induce. We put them into, we then recorded all of that while we're doing it by the signals going directly into recording. And then offline, we played it back through transvenous defibrillators of all the three major companies, as well as a sub-Q ICD to say, how would this have responded to that? And somewhat to our surprise and to their pleasure, the subcutaneous ICD actually beat all three of the companies and easily beat them. So there was only a 2% failure rate of appropriately detecting that this was a non-shockable rhythm, AFib, SVT, sinus tach, whatever, or a shockable rhythm, VT or VF. So it performed very well with this algorithm that's built into the device. Based on that, the FDA went ahead and approved a study. IDE is a study for approval that you have of this device. So the first phase of this device was mostly based on acute testing. So patients got the device implant. You needed to induce ventricular fibrillation, which you can do with this device. And it turns out that 99.9% of them appropriately detected it as ventricular fibrillation. Interesting, the one failure was not truly a failure. The device had detected it because the device takes time to detect it. It was starting to charge up, and the implanter got nervous, and he shocked the patient. And even though he knew it was going to get shocked at some point, he got nervous, and since he shocked it, that was the one failure. And then for success, it had to 2 consecutive times at 65 joules. The device only puts out 80 joules. It's not programmable. So a 15 joule safety margin was 100% successful. So the FDA was happy with that, led to the approval of the device, which went into study and then was approved. Because the device can only give 80 joule shocks and nothing else, There are two zones in it. One is called the conditional zone, where the algorithm's turned on. The other is a shock zone, meaning at that rate, it's just going to give a shock. Many people were just programming the shock zone, saying, what difference does it make? It's going to be 80 joules no matter what we do. And it turns out what we showed from this initial study and analysis is that if you use dual zones, meaning you're going to allow the algorithms to work, you markedly reduce the number of inappropriate shocks by 50 to 75%, depending on what they were due to. So the algorithm works in real time as well. Well, standard FDA policy is to do a post-approval study. So when a new technology comes out, the FDA wants to know what's going on. And for this study, we designed a very large 1,600 patients that were going to be followed for 5 years. Has to be a diverse population to satisfy them. So academic and private groups doing it, large groups, small groups, very experienced implanters and not so experienced implanters, rural, urban, whatever, to get their approval for it. And we followed them over time. The IDE study, which was the first study, had a lot of cherry-picked patients, not so sick patients, and the equivalent in Europe was the effortless study, which got that study approved. And I'm not going to show you those data for the sake of time. But what was important is that with this post-approval study, these were a lot sicker patients than what we were putting in the early forms. And people were a bit skeptical, is this device really going to work in truly the sick patients we see? So we can see the ejection fraction was 32 rather than 42%. 3 times as many patients had heart failure, 3 times as many patients had hypertension, 3 times as many patients had diabetes, 3 times as many patients had kidney disease. So it's a much more typical population, although it's a little bit younger than what we're probably used to. But still, it was a sicker type of population. And what we showed, and because it was a long 5-year follow-up, we just published it actually last year, but appropriate shock efficacy for first shocks was over 90%. For any shock was over 98%. And it says, why are we missing a couple of those? This is exactly what you see with transvenous devices too. For VT storm and other things, you get failures and other things that occur. Storm episodes, again, were in the 90% range before something had to go in afterwards. Again, very typical. And very encouraging was that over the 5 years, there was no decrement in the value of this. We had no idea whether scarring or anything else was going to make these less effective, but they remained incredibly effective, through this 5-year period. So all good news. There's standard cutoffs that the FDA uses for every defibrillator trial, whether it's transvenous, whether it's subcutaneous, whether it's hybrid or whatever. These performance goals, which you can see on the bottom here, of 94, 84, so on and so forth. Every one of these were achieved, which was obviously very good news. And the device performing as well as what a transvenous device has to do to get approval from the FDA. Inappropriate shock rate was a problem, and again, bothered many people appropriately. It was 6.7% at 1 year in this study, which is even better than what we were seeing before for the IDE study, which was much higher than that. And then it was 16% over 5 years. And there are a couple of predictors of that, such as if we heard a little bit about the screening tool, if only 1 out of 3 vectors work, there's a chance you're not going to succeed there. Dialysis patients, atrial fibrillation patients, what you'd expect to be potential patients would be a problem. And about 85% of the inappropriate shocks from this system was due to some sort of oversensing, either cardiac, T-wave oversensing, so on, or occasionally non-cardiac oversensing from EMI or some other factors like that. Complication rates were fairly typical for device studies of 7% at 1 year. Then the complication rate goes way down. It less than doubles over the next 4 years of this, of 13.5 years. The idea that these patients don't get infected is not true. Patients can get infected. It's pretty similar to transvenous devices. If you don't have good technique or for whatever reasons, they're almost all pocket infections, occasionally a lead infection of 3.8%, and very few after the first year or two, because either it's going to be there right away, you're not going to get hematogenous spread to get these infected, and not a single patient had bacteremia. So 1,600 patients, not a single patient with bacteremia. And in terms of lead failures, out of 1,600 patients, and we already talked about, what the rate of lead failure are in transvenous leads. In 5 years, there was only one failure of a lead out of 1,600, and that was a twiddler who was like basically twiddled his device into failure. So incredibly robust because there's no lumen in this lead. This thing is like a steel rope. You could tow a truck with this thing, with this lead, before it would break probably. So the next major study that occurred was the Praetorian study. This was a randomized study, the first randomized study of an SICD versus a transvenous lead. It was done largely out of Europe. Reynard Knops in Amsterdam did the study where patients who were eligible for a single chamber ICD, that they did not need pacing either for ATP or for bradycardia, or didn't need CRT, were randomized 1-to-1 to either get a sub-Q or a transvenous ICD. About 850 patients in this study. And as we can see, this was again, a very typical group of patients for defibrillator implants. 2/3 of them had ischemic cardiomyopathies. Secondary prevention was allowed in almost 20% of patients. Median ejection fraction was 30%. So again, these are the patients that we're all seeing and all put defibrillators into. The primary composite endpoint was inappropriate shocks and complications. There was no difference. This was a non-inferior study trying to show that this can be a substitute for transvenous ICDs. It was, in fact, non-inferior, very similar between the two of the total complications or inappropriate shocks. But if we try to see how that broke out, inappropriate shocks were significantly lower with the transvenous ICD because of the problem with inappropriate shock to the SICD, but the device-related complications were significantly lower with the SICD. So they offset each other to make this a neutral result. If we look at these complications, there are some obvious things that stand out. You get rid of pneumothorax, you get rid of lead perforations, very few lead repositionings needed, very few lead replacements. So it's mostly the lead-related stuff or the procedure itself to put a device intravenously. And if we look at these lead-related complications, obviously it was 75% reduction in an SICD compared to transvenous ICD in this study. So it served the purpose of essentially minimizing lead complications. One of the, I find it's a very interesting aspect of things, was looking at VT-VF therapy. So one of the perceived downsides is that it's got to give you a shock. So if you go into VT, if you can have a monomorphic VT, you can't pace terminate it with this device. So if you just look first at, in the two arms, randomized study, what was transvenous versus sub-Q time to first appropriate therapy, ATP or shock? It was the same. Not surprising, there shouldn't be a difference in these populations randomized of what the chance of them having VT or VF. So it was the same, so it suggested they were well balanced. But if you look at the first appropriate shock only, so if the first therapy was just a shock only, was a shock, the SICD was more common than the transvenous ICD, because some of them, the transvenous ICD, pace terminated. Again, there should be no surprises here, hopefully, to anyone. This showed that they did a well-balanced study. So that's the effect of the ATP. One can argue, and I won't share this slide, but it was only 20% of patients had these events. So 80%, it didn't make a difference what device you had in. But still, there's a benefit from that first shock. But what was so interesting to me is that if you look at the total number of shocks, not that first shock, total number of appropriate shocks now, there was no statistically significant difference between the two. So you scratch your head, why, if you could give ATP, was there no difference between the two? And when you look at this, there was a lot of ATP, but there was not much difference in the total number of shocks. So if you look at discrete episodes, you have a single episode of arrhythmia, whether it's a VT or VF, as expected, the SICD shocked the patients more often because you got some patients out of it. And that's because of all the ATP that you can see here. But when it came to VT storm, that's when things fall apart, which is the interesting aspect of this. In patients with VT storm, they were having multiple episodes. There were many more shocks given in the patients who were able to get ATP in this and who got a bunch of ATP for this. It was either re-stimulating the heart or whatever the purpose it was doing, but it was about 50% more shocks if ATP was turned on compared to simply just giving a shock to these patients. And that's what counterbalanced it. So the total number of shocks the patients got didn't differ, but it was the VT storm patients where it made a difference. The next randomized study I want to show you is the Atlas study. This was a study out of Canada. Again, a randomized study of about 500 patients. So we all have good numbers with this. And what they wanted to look at was, again, just this lead issue. And they were looking at it, this is a more modern study than the Praetorian, so it's the emblem, the more recent generation of devices and leads. And what they show, you can see here on the far right, is that lead complications requiring an intervention was 4.8% in the transvenous arm versus 0.4% in the arm of the SICD. So again, further, I think, confirmation that the lead is a very safe lead and it achieved its purpose of what we wanted to do. They did a sub-analysis, which again is, I find very intriguing, was to looking at tricuspid regurgitation. Shown here on the left-hand side is nothing to do with ICDs or nothing with leads in the heart, but patients with tricuspid regurgitation have a higher mortality. The more TR you have, the more chance that you're going to die over time. And it has nothing to do with, again, a lead or anything else being there, but has to do with, presumably why the patient has tricuspid regurgitation in many ways, or the tricuspid regurgitation leading to RV failure or pulmonary hypertension or something else. The literature and our understanding in devices is not well developed because people talk about it. We often get asked, do you think his TR is due to his lead? Can we take his lead out? Can we do this? And most of the time we say it's not the lead, unless the lead's perforating, one of the leaflets, it's not the lead. They're not going to get any better and so on and so forth. But there's been no randomized study until this arm of this study was done. And the Atlas study, and very interesting. So what they showed was that if you just look at the amount of TR, patients randomized, they did echoes beforehand and very strict methodology for it. And then echoes after just 6 months follow-up, you're about twice as likely to have any TR with a lead crossing the tricuspid valve compared to those who didn't. So 42% versus 19%. And the odds ratio there, and there was about a 7% incidence of moderate to severe TR that was seen with the transvenous leads. So the odds ratio of having at least 1 grade worsening of your tricuspid regurgitation was 7-fold if you have a transvenous lead. That's over just 6 months. So it makes me rethink, because I've been sort of poo-pooing that, I don't think leads cause a lot of tricuspid disease, but clearly they worsen tricuspid regurgitation. And these are defibrillator leads, which are bigger than pacemaker leads. I can't tell you what the data would be in pacemaker leads or not, but clearly a problem. So moving on to where we've gone even further, because of the problem with inappropriate shocks, we had worked on a new algorithm, which essentially is a filter to change the filtering process to try to get the T waves out of the picture and some other things out of the picture. And we did from a large collection of arrhythmias from subcutaneous ICD patients. We did testing offline in the lab, in the bench testing, and showed that this should be a very good thing. This should reduce the amount of inappropriate shocks significantly. But this has not been shown in the real world. So part of what we wanted to do was this study called the Untouched study. This was, again, another very large study. This was over 1,000 patients. This was not a randomized study. This was a multinational study in which we took patients for 18 months. And what we did different in this study is we were prescriptive with the programming of these patients. So we said the conditional zone had to be turned on, and it had to be turned on at 200 beats a minute. So we're not going to address any arrhythmias that are less than 200 beats a minute. And we're going to leave that conditional zone all the way up to 250 beats a minute. So fairly gutsy thought at first that, so this is going to continue to work up until 250 beats a minute. It's only over 250 beats a minute that it will automatically give a shock. I mean, at 205 beats a minute, it can determine that it needs to be a shock anyway. It was only in primary prevention patients. So we didn't want patients who've already had an arrhythmia, particularly VT or something like that. And they had to have an ejection fraction less than 35%. So this is typically mated to Scott Heft sort of population. They obviously had to pass the screening. They could not have had spontaneous VT or VF because we didn't want to have someone with a VT at 180 beats a minute, no Brady indications, no CRT, and didn't want class 4 patients because they'll probably die before they get to 18 months or get transplanted or something. So if we look at this population, this is the sickest population ever studied. 1,116 patients. The mean ejection fraction is 26%. More than half of them had ischemic etiology. AFib was represented, about 90% had heart failure. So this is our true sick patients that we're putting devices into, well treated medically. And what we saw, again, we had this performance goal, but the inappropriate shock rate at 18 months was 4%, which was 2.7% per year. So that is very low. It's even lower in the ones who had this new algorithm turned on, which I'll show you in a minute here. So this is the history of the subcutaneous ICD on the left. So the first study, the IDE study, was 13% annual inappropriate shock rate, all comers. The effortless study, which is the European study, was 8%. The post-approval study was about 7%. Several other studies. Then the untouched study overall was 3.1%. And the untouched study using with the algorithm turned on, the SmartPass algorithm, was now 2.4%. And what I show you on the right is the best data we have for transvenous leads. These are all the studies that emphasize prolonging detection rates and all of this stuff. The Advanced 3 study, MATED RIT, all of those. And we look at what those are. They're all between essentially 4 and 6% 1-year inappropriate shock rates. So if I wanted to be overly enthusiastic, I could say the subcutaneous ICD is actually better than transvenous leads now for inappropriate shocks, but these are not randomized data or anything else. So, but clearly there's no risk or no loss from a subcutaneous ICD in terms of inappropriate shocks when you look at what the modern day treatment that we have for this. So, very encouraging data. And despite this programming, of 200 and 250, first shock efficacy was 92%, final shock efficacy was 98%, final conversion rates for VT Storm was 100%. So again, it still performs at a very, very high rate, despite that sort of programming, which, we would argue, should be sort of pretty standard programming to minimize this, particularly in young patients. So we were very, very pleased with the results of this. We published this in Circulation a few years back, even though it was later data than we have with the other ones because they had longer follow-up. So I just want to turn to, the new kid on the block, which is the extravascular ICD, which you already saw a little bit about this, where it goes under the sternum, but over the heart. Seems a little spooky at first, but it seems to work okay. And it got approved, recently. The defibrillation thresholds are lower with this device. We can see here that almost all of them were less than 30 joules. It's a 40 joule output device, which allows it to be a smaller device than an 80 joule device. Battery takes up a lot of space. 6 months, the complication rates were relatively low with this device, which was good, but similar to the same sort of cutoffs the FDA uses, clearly made the target, for approval based on that, which was all good news. Spontaneous arrhythmias in about 70% of patients, about 2/3 of patients. The ATP work to be able to terminate the arrhythmias. It doesn't give standard Brady pacing, only sort of, in terms of, for real bradycardia or asystole sort of pacing it has in it. Inappropriate shock rates were high. It's concerning. It was 8.5% at 6 months. So again, this will get better over time as they sort of learn. A lot of this was actually P wave oversensing, double counting on P waves rather than double counting on T waves. But just like the SICD, there's a growing period, a learning curve to get this better. So this will need to get better because you don't want to have, nearly 10% of your patients getting an inappropriate shock within the first 6 months. That's going to bring back bad memories of stuff, but it'll get better, I'm sure, although I'm not part of what it will do. So future devices for the subcutaneous ICD. This was in the future device section, the extravascular ICD, but it's now approved, so it's not in there. So a very interesting one is combining a leadless pacemaker, which can communicate with the SICD. So you now have pacing in the right ventricle to give ATP or Brady backup, and you have a subcutaneous ICD. So you don't have any leads inside the heart. The other sort of, I think, hidden benefit of this is that inappropriate shocks are going to get even lower because any sort of double counting on the SICD, the leadless pacemaker will not see that. If it's a leadless pacemaker, it's half the number of beats as a sub-Q. It was a double counting incident, so it'll prevent some of those as well. So this has been in clinical trials. There was some manufacturing glitch or something which slowed it down a little bit, but this is a Boston Scientific device, but combination. But it's got to be their leadless pacemaker that has built in a communicator with the sub-Q ICD. It's not just putting a leadless pacemaker into anyone as two separate devices. They actually communicate together. So this will be interesting. It'll be obviously more expensive. But the early studies of this, showed that ATP was successful for terminating VT, and, it certainly paces well, like everything else. So what is the future of ICD? We already heard someone waiting till they were in a nursing home till they, when we get this. I actually proposed this in 2015, so it's now 9 years later. I wrote this in some editorial, and Jack, the editorialist there, did a very nice job making this diagram for me, of having leadless pacemakers in the LV and the RV. The LV, we have a bullet now that EBR makes, that has a separate ultrasound device, and we just published those data, but I didn't want to bring that into this. That gets a little more complicated, having two devices on the chest and so on and so forth. But I don't think we're that far away. It's still some years on the road, but I think we're going to get the leads out of the heart altogether in the not too distant future, which will be nice. So just in summary, I think the ICD remains a fundamental component of sudden cardiac death prevention. Don't diss it because there's problems with inappropriate shocks or whatever. It saves many lives every day. Transvenous leads were the standard for more than 20 years. But now the SICD, the completely subcutaneous SID, and whether it's the extravascular or this was developed, they have excellent safety and efficacy for patients without the need for pacing. If you don't need pacing for either of those, certainly something to strongly consider. Complication rates are low now, high shock efficacy, and very low inappropriate shock rates with contemporary devices. Even in patients with advanced heart failure are there. So anyone who doesn't need pacing indications, in my opinion, we should at least be considering this in those patients. And these newer devices are going to make it even better with leadless pacing and understanding better how the extravascular ICD works. So thank you.